Hello and welcome to Ask the Expert, our questions and answer live stream on Facebook. My name is Paula Hanford. I'm quite new. I keep saying that. I'll have to stop saying it soon. I've been here at PSC support for 5 months. So I'm the relatively new CEO, and I'm absolutely honoured to be in this position. I'm delighted today to be joined by Dr. Jess Dyson. Dr. Dyson is a consultant hepatologist at the Freeman Hospital in Newcastle and an honorary clinical senior lecturer at Newcastle University. The Freeman Hospital in Newcastle is just one of 8 liver transplant centres in the UK. So we're in really, really good hands today. Dr. Dyson has a specialist interest in immune-mediated liver diseases like PSC. I have to read this, I'm afraid, so just bear with me. She's the principal investigator for UK AIH on the steering committee for the Basel Immune-Mediated Liver Disease Special Interest Group, a member of the International Study Group for PSC and AIH, and a contributor to the Lancet Commission into liver disease in the UK. So as I mentioned, we're in extremely good hands today. And I'm really excited for Dr. Dyson's presentation because it's about the environmental factors that may contribute to the development of autoimmune liver diseases. So the areas that we live in, the things that we interact in on a daily basis may contribute to autoimmune liver diseases. It's something that's really discussed quite a lot on our forums, on our Facebook group. So I'm really looking forward, and I'm sure you are too, to learning more about the issue. After that, we're going to open the floor for questions. So please put your questions in the chat box. And if you are, if you're watching us live, of course, if you're not watching us live, you can't put your questions in the chat box. But if you're watching us live, put your questions in the chat box just below the video. And just finally, a reminder that Dr. Dyson cannot answer personal medical questions for individual medical questions. She doesn't know your history, and also we've never discussed that in front of other people anyway. So just please keep your questions very, very general. So I'm going to hand over to Dr. Dyson. Welcome, Dr. Dyson. Thank you very much for joining us. It's great to have you with us, and over to you.
Thank you so much, and thanks PSC support, Paula, Martine, and my apologies. I'm on call and then had a complete IT failure, so it's my fault we're running a little bit late. Now, I shall endeavour to share my screen, which we did a practice run just now, and it did work. Can you see that, Paula? Thumbs up will do. Yes, good, lovely. So, as Paula says, kind of various interests, but particularly, so this is some work based really coming from my PhD, thinking about environmental triggers, factors, associations in autoimmune liver disease. Now, obviously, thinking about the people we're talking to you today, so I've really focused on PSC and time constraints, and I could talk about this topic all day long. But we'll start with we'll focus on PSC and obviously discuss any questions you have afterwards. So now, can we move the slides? That's the question. Oh, yes, we can. How exciting. So background, I mean, I'm teaching my grandmother to suck eggs a bit, but we all know PSC, rare disease, 7 per 100,000 population, roughly. Inflammation, scarring of the bile ducts, both inside and outside of the liver, leading to narrowings or strictures. We can have small duct PSC, so features of PSC on liver biopsy, but without those abnormalities on an MRI scan. And a very high number of patients with PSC also have inflammatory bowel disease, which is important, I think, when we're thinking about why this happens. PSC, as we all know too well, is a real challenge for patients and you know, clinicians looking after people. We struggle in terms of understanding why this happens and having good treatments. And, you know, varying presentations. Some people have no symptoms and are found to have abnormal liver blood tests that triggers a set of tests. Some people fatigue, itch, also recognised in PSC as well as more commonly recognised in PBC. Some people have discomfort or pain even, weight loss, cholangitis, so infection within the bile ducts, gives you this trio of jaundice, yellowing of the eyes, pain and fevers. And even people directly presenting with complications of cirrhosis. And thinking about why this happens to people, a question I have to say is probably one of the commonest questions I get asked. In epidemiology, the study of why disease occurs, PSC potentially is becoming more common as time goes by. We also probably look for it more thoroughly. So there's a high rate of PSC in Scandinavia, although we do acknowledge there are different screening practices. Some countries, every patient with inflammatory bowel disease will be looked for PSC, so for example, with an MRI scan. And it's a very variable disease. We've talked about different types of presentations, but large duct, small duct, itchy, not itchy, inflammatory bowel disease, not inflammatory bowel disease. So if we're thinking about a rare disease and then subgroups of patients in that rare disease, that makes understanding causes and identifying treatments really challenging. And thinking about the environment, well, there is some suggestion that although there's a genetic component to PSC, it is not directly passed between generations. Again, one of the commonest questions I get asked about screening. But environmental pollutants, so this picture on the top right here is taken from a paper in America, and looking at patients with PSC and how close they lived to toxic Superfund waste sites, what we would call kind of landfill sites in the UK. And the red hotspots, if you like, show higher numbers of patients with PSC living next to some of these landfill sites, raising this story of whether there's toxins or pollutants related to disease. However, along the bottom here, you can see a table. Essentially, this table is taken from another study looking at whether an urbanness of a location was related to disease frequency, how many people with PSC lived in that area. And the answer in that study was no, there was no relationship. And this is a really detailed kind of lifestyle questionnaire type study looking at risk factors in an individual's life compared to somebody who doesn't have PSC. Smoking bizarrely seems to be protective against PSC, although that is not an advert for people taking out smoking, just to be clear. Having your appendix out seems to be associated with a higher risk of PSC. Ever having used hormone replacement therapy in women seems to be protective. And recurrent urinary tract infections seems to be a risk factor for PSC. Again, very much mirroring the PBC story. And they also went into loads of detail about diet. And you can see here on the right, I've highlighted fish, and lots of fish in the diet seems to be a protective factor against PSC. Again, pointing to diet, risk factors, lifestyle, etc. And the microbiome, quite a sexy topic at the moment. Essentially, gut, liver, lots of crosstalk between the two, bacteria, other organisms, and potentially, dysbiosis, so changing the bacteria in the gut may trigger the immune response. Lots of factors influence it, whether you were born by cesarean section versus vaginal delivery, diet, infections, antibiotics, hygiene, and even mood supposedly affects the gut bacteria in your gut. A key area, but yet for us really to understand. And thinking about the study that we led here in Newcastle, so we looked for all patients with PSC in a tightly defined area and trying to understand evidence for environmental factors relating to rates of disease. So are there areas of PSC prevalence, so numbers of patients greater than one would expect by chance? Was there association with the environment? And was there a relationship between socioeconomic status and disease risk? This is the northeast of North Cumbria, where we did the study in the United Kingdom, a really kind of heterogeneous mixture of urban and rural landscapes. We've got a pretty stable population of about 3 million people with low migration rates, helpful for doing this type of work. And I spent many a happy, year or two looking for people with PSC. And we found nearly 500 patients between the 1970s and 2018. 68% of the male, which kind of reflects what we expect to see in our PSC populations. It's predominantly a male disease, and a median age or average age of diagnosis of about 50, again, probably mirroring what we would expect. And we did various types of modelling. So this is all kind of statistics, but at its most simplest, we look for presence and patterns of clusters, whether groups of patients in space or time. We also then tried to estimate the relative risk of disease and look for if there were clusters of patients, where those people lived, and whether there were potential risk factors in the environment that could be related to high risk of disease? And the answer to the question is yes. So there is disease clustering. Here on the left-hand side, this is just a heat map. The red and kind of pinky and orangey areas are areas with high rates of PSC across our study region, so the North East and North Cumbria in the UK. But if you have more people in an area, you will get more disease, almost definitely. So in the middle here, we're then controlling for numbers of people in the population. So you're not just seeing more disease where more people live. And then on the right-hand side, this red-green map. So this is setting really quite tight confidence intervals. So this is what we call a kind of significant risk of PSC. And you can see a hotspot over in the western side. So that's Cumbria, which is a very rural area, where there are high rates of PSC. And then conversely, over right on the east, so this is the very urban areas of Darlington and Teesside, where there's a low risk of PSC. Again, pointing to environmental triggers. And we can think about various points of interest in the landscape. So urbanness, we've thought about landfill sites, mining, quarrying, all of which disturb the environment around us. We can actually look at areas of levels of heavy metals in the soil. Heavy metals are well known to be risk factors for cancer, triggers for the immune response. And we can also think about social deprivation, and there are various measures. We use Townsend score and the IMD, as it's so called. The top right here is sampling sites. So lots of sampling sites, thousands and thousands across our study region, where we get actual physical levels of heavy metals. And then you can do these kind of heat maps on the bottom right here. This is just one for urbanness. Bright yellow is the very urban areas. So this, as you might expect, maps onto the big cities in our region. And this is a busy slide, but I've picked out the two key messages for you here. So PSC, if you start looking at the individual risk factors, we've already shown that there were disease clusters. But when we look at urbanness, so the values here were all negative. So actually there are higher levels of PSC in more rural areas. And along the bottom here, we can see the Townsend score. So remember, this is a measure of deprivation, socioeconomic status. And again, this is a negative score, significant relationship between deprivation and disease, but it is a negative relationship. So actually, there were more patients with PSC living in more affluent, better off areas with lower levels of socioeconomic deprivation. And then just a quick note about this other form of modelling we did, so structural equation modelling. Essentially, it's looking at interactions, because no factor, well, generally speaking, nothing happens in isolation, does it? There's crosstalk, and this is the model, excuse me, we designed. Lead mines lead to high levels of lead in the environment. Urbanness has more traffic, etc. And looking at all these kind of interactions with autoimmune liver disease, and for the purposes of this talk, PSC being the kind of ultimate outcome measure. And here, so the structural equation model for PSC flags up arsenic and lead really as being the kind of related risk factors, and arsenic particularly giving us or accounting for 18% of the variation in disease risk. So higher levels of arsenic and disease risk. And you've seen this map on the top right before. So the high levels of PSC over in the rural western side of our region. And if you look at the heat map of arsenic, it maps beautifully onto the high levels of arsenic in the environment. So again, pointing to association potentially. So to conclude, I would say that we have demonstrated disease clustering in PSC. So this is a distinct area, but you could do this work anywhere, provided you had the comprehensive data. So we're seeing higher rates of PSC than one would expect by chance. There's higher rates in more rural and less deprived areas. And the association with rurality, is it something about the area? Is it the high rates of farming? Is it the use of pesticides, which historically used to contain heavy metals? And the inverse association with social deprivation is very unusual. Many diseases, including most liver diseases, certainly alcohol and fatty liver disease, and hepatobiliary cancers, which, as we know, sadly are very common in PSC patients compared to the general population, they're usually much common in deprived areas, but we're seeing the opposite in PSC. Generally speaking, there are poorer levels of overall health in deprived areas. So I would say there's a definite, well, I'm a big believer, as you might imagine. I think there is a story about the environment in PSC. I think there's a huge amount of work to be done, and we still have lots and lots of unanswered questions. And remember, association is not the same as causation, but I think if we can explore those relationships, it may help us. And the heavy metal story, for example, I think is something I'm keen to look at further. We know that heavy metals cause cancer, heavy metals cause activation of the immune response, and we're seeing a relationship between arsenic and less so lead with PSC. I know the time is tight, so I shall stop talking, and I'm more than happy to try and to answer any questions that people may have. Thank you very much.
Thank you very much, Dr. Dyson. It was really comprehensive, running us through some of the environmental factors that might be in play with PSC. Anybody got any questions? Do you want to put them in the chat box, please? I have a question to start us off. Do you think there will ever be a single environmental factor in PSC? You've mentioned arsenic and lead. Do you think that arsenic is the main environmental factor that we've discovered at the moment?
So I don't think there will be. I think, to be honest, most diagnoses, liver diseases, all sorts of other things, I don't think you can pin it down to one. And I suspect we'll understand. I mentioned a little bit at the beginning, you know, PSC, as we all know, is pretty variable, isn't it? If you ask lots of, you know, when the patients I look after, the stories, the presentations, the experiences, the outcomes are different for, you know, a lot of individuals, and I'm sure people on the group would kind of resonate with that. So I suspect there's different risk factors, you know, why some people have inflammatory bowel disease, some people don't. There's so many variables, and I think that is really one of the challenges, isn't it? Because to truly understand a disease, you have to, well, ideally you would like to understand what causes it. And I think I don't think it is a single story, because it's I think because it's a multi-gene disease. So, you know, there are some diseases that are one gene defect passed down from generations. If you can change that genetic defect, I mean, it's easier said than done, isn't it? But because PSC isn't like that, it's not a single gene story, I don't think it's a single environmental risk factor story either. And I think that's really the challenge. And PSC is not alone in that. Certainly all the autoimmune liver diseases, and I think most immune system problems, the same is true.
So if we identify arsenic and you live in that particular, what can you do to minimize the risk?
Well, no, and I think that's again an important question, and why I make the point about causation or association is not the same as causation. And I've always been anxious, might be overstating it, but wary of saying A plus B equals C. I think the data we have is very interesting, but high levels of arsenic, whether that in isolation, I don't think we have enough data to say that causes PSC. There is an association between arsenic levels. Now, of course, that could be a surrogate marker for something else, couldn't it? If we could, your point is a good one, that if we could understand, you know, asbestos, I suppose, is a good example, isn't it? We now understand that asbestos causes mesothelioma, a certain type of lung cancer in people, and you take the asbestos away and the lung cancer, that type of lung cancer risk went away. If we could do that kind of direct causation work, that's a different matter. But I think at the moment we don't have the evidence to say A plus B equals C. So at the moment, I don't think you could modify diet and of course arsenic, you know, for example, I mentioned pesticides. The organophosphate pesticides that were used a lot historically, that contained lots of heavy metals, are no longer on the market. They were banned because of environmental pollution, because of the known cancer risk, etc. So actually historical risk factors may well have got to a certain degree. So whereas we're probably seeing more PSC. So it's not just that as a single factor, because PSC is probably increasing over time. I think it's just much more complex than a single causative problem.
I think you just asked this question. You just answered this question, but somebody asked, "Is there any correlation with diet, in your opinion?"
Yeah. So the story about that study I just showed a slide about by Eaton et al. And they did a really comprehensive dietary. dietary history, if you like, from patients. And actually, they, to the degree we didn't have time to go through it in so much detail, but they even asked how cooked you like your meat. You know, if you barbecue a steak, do you like it burnt effectively? And the thing that came out as being quite protective was this eating fish. And I think the oily fish story, the omega-3 oil story, that are potentially good for you in lots of diseases, that's probably the only thing that has come out as being kind of potentially beneficial. I don't think there's any evidence of harm with things like omega-3 and oily fish and things. So, and some of my patients are big proponents or supporters of various type of diets. And I'm always kind of, I don't poo-poo that, because just because we don't have data doesn't mean things are good or bad. You know, today I think generally speaking, we say healthy, balanced diet in that terribly irritating way that doctors tend to say, because the data doesn't support but other things. But I think there is some data about kind of fish, omega-3, etc.
Great. I've got a question here about, have you done or seen similar studies with inflammatory bowel disease, and is there a similar pattern?
So that's a good question, and I'd quite like to do the same work with inflammatory bowel disease. It'd be quite nice to do it in the same geographical area, wouldn't it? And then you see the story with IBD. The reason we haven't done it in our area is because that cohort of patients doesn't exist, in the sense that to do true studies of this nature, ideally you need every patient with that disease in a study area over a defined time period. And now that is pretty tricky to get. Inflammatory bowel disease, we could, because it's, I don't want to bore you with the details, but because it's coded much better, the way the government effectively record inflammatory bowel disease is much more reliable than PSC. PSC is not well documented, so we could do it. There are so PSC, inflammatory bowel disease, sorry, there have been kind of lifestyle questionnaires, etc. The smoking story is, I think, is bad in PSC and good in Crohn's, supposedly, or vice versa. So that data that has been looked at, but to my knowledge, there hasn't been a kind of drilling down of PSC, colitis, non-colitis, because again, I think because it's a rare disease, as soon as you start subdividing, if you like, that makes it pretty tricky. And you know, are you on infliximab? Are you on azicol? Are you on ustekinumab? All of a sudden, as soon as you introduce treatment subgroups as well, it all then becomes very, very tricky.
Okay, thank you for that. There's another one on diet, actually. What is Dr. Dyson's thoughts on the DINA study, where participants eat a low sulphur vegan diet and have decrease in ALP? Can sulphur in the tap water play a part?
Very interesting, and I have to confess I'm not aware of that study. There's no point in me bluffing if I don't know the answer to the questions. I don't know the answer. Sulphur in itself, I can't. We didn't look at sulphur because sulphur is not documented in the same way in the terms of the data collection. So our data came from the British Geological Survey, which is fantastic. It's a free data resource, actually. It's fantastic, but we didn't have sulphur data. So I don't know, but I will read about it. So thank you for flagging it up.
This is a good question. Again, kind of diet related, but also about the heavy metals in the soil related. So if it's a really good question, I think, actually. So if there's a correlation with heavy metals in the soil and our food is being grown in that soil, then is that how we're getting those heavy metals into our bodies? No,
I think that's a really good question. And I think exposure and routes to exposure is one of the things that's really interesting. And as I say, the talk is only short today, and I could talk about this all day long. So route to exposure is really interesting. So again, occupation is, you know, the story about what you do. If you're a miner, for example, again, you've got, you know, miners get lung disease from all the coal or dust rather. Diet, job, where you live, all of those routes to exposure. Pollution in the soil, pollution in food, or not even pollution, but what's in your food. It doesn't necessarily mean it's a pollutant, does it? But things that you eat, things that you drink. have looked at things like, for example, fire. A lot of the fire retardants, particularly the ones that used to get used on sofas, for example, which are good because they stop your house burning down, but they may have, you know, toxins in them, and those could be relevant. So routes to exposure, and I think occupation as well, I think is potentially interesting, in diet. So for example, I think there was a question about food. So for example, broccoli is grown specifically for the purposes of, this is a clever word, phytoremediation. So that's just a posh way of saying soaking up. It's like they soak up heavy metals, and they are grown in some areas specifically for that indication. They sump heavy metals in their, presumably in their like fluffy head bits. So I think that is a really, we've part of my PhD, which we've not published yet because we got a bit carried away with the amount of data we collected, but it's exploring, you know, did you work on an allotment in your 20s, 30s, 40s, 50s? Did you dye your hair in those decades? Did you have antibiotics? But it's fascinating, but the detail of that data is we have looked at it, or we started to look at it, but it's very difficult to analyze meaningfully anyway.
Yeah, I can imagine. This is an interesting question. Have we been too clean? My mother was always cleaning and bleaching, and I probably used too many chemicals to clean. That's the question.
Well, so yeah, this goes back to this kind of concept of the hygiene hypothesis. So there's quite a lot of stuff, particularly relating to immune disease. Generally speaking, immune diseases, of which, if we say PSC is an immune-driven disease, are getting more common with time. And there is some suggestion that, so your immune response is designed to protect you, isn't it? And, you know, from infections, from, you know, little critters trying to cause problems. And your immune system, PSC or rheumatoid or thyroid diseases, because your immune system has got a bit overexcited and has started attacking individual bits of your body. And actually, are we being too clean? If you roll around in the dirt as a child, your immune system has to kick in to stop you getting infection. Whereas actually, if we're very clean and we're very sterile, are we removing the immune system's ability to respond? There is a, as I say, it's called the hygiene hypothesis, and is the reason that we're seeing more immune system disease over time because we're becoming cleaner, too clean, you know. And it would be, you know, the COVID, I mean, not talk about COVID because that makes everybody sad. But of course, we've had this whole period of everybody being incredibly clean, haven't we, and incredibly isolated from other people. I think the hygiene thing is an interesting concept. Can we be too clean?
It is very interesting, isn't it? It doesn't happen in my house. I've got no danger of that. Another question on the arsenic in the soil, really. Has the Cornish mining community, do you know, been studied regarding a link between its arsenic production in the 1830s and liver disease? So
no is the quick answer to the question, or not to my knowledge. But and this isn't PSC actually, but PBC, so primary biliary cholangitis, kind of sistership, if you like, of PSC in some ways. So I think there's probably the mining story, whether that be in Cornwall, but South Wales and the northeast of England, and Cornwall to a lesser degree, are the kind of mining hotspots, if you like, in the UK. And actually, South Wales and the northeast of England are hotspots for PBC. And cadmium, so again, another heavy metal, is the heavy metal that we've shown association between PBC and cadmium. And so and cadmium is associated with coal mining. So there's a whole Lincoln story there as well. So whether actually whether the common thread in those two areas with high rates of PBC and high rates of cadmium is coal mining, disturbance of the land, higher exposure rates to cadmium, is potentially interesting. The Cornwall, that data does not exist to my knowledge in terms of the rates of PSC. The data will exist in terms of rates of arsenic in the soil. That data will exist because the BGS will have it. but the data doesn't exist in terms of a PSC cohort study, as far as I know.
Okay, thank you. So the next question says, hi, person says, hi, thank you. Nice to see a stats presentation. Are there any studies to look at the connection between autoimmune diseases? This is slightly different to the presentation, I know, but for example, my husband has ulcerative colitis, then AIH and PSC overlap, and there seems to be similar that patients don't just get one disease.
Yeah. No, what we tend to discuss when people see me in clinic is this almost kind of, it's not a very medical term, but families being a bit kind of immune. So, you know, it's quite often, I suspect people on the call will probably kind of recognize this idea that one person has PSC in the family, another person has underactive thyroid, another person may have celiac. So although these aren't genetically inherited diseases, which points to a question I can see popping up about passing it on in families, but we often see that an individual may have more than one immune system disease. So actually somebody will have celiac and AIH and inflammatory bowel disease. And then also in families, that a family will have quite immune activity, quite high levels of immune activity. So, and for example, the multiple sclerosis, which is probably at least in part immune driven, has a very, very similar genetic makeup to PBC. But the number of people with, I mean, I could count them on one hand. I look after, I don't know, 1,000 people with PBC, probably more. But I could count on one hand the number of people who also have MS. So although that genetic background is very similar, they're probably the closest immune diseases in terms of genetics. The actual in day-to-day life of people having both of those diseases is very unusual. So it's not just the genetics that are telling the story. But yeah, undoubtedly it is well recognized that if you have one immune disease, you could have another one. So we do see that quite a lot. Thyroid's probably the commonest one.
Okay, thank you for that. Next question is, can you offer any suggestions at all, however speculative, of any practical advice you could follow as PSC patients to reduce our exposure potential environmental triggers? We've touched on that a little bit already, haven't we?
That is a good question, and I think, and it's one that everybody, I think, particularly for a situation where actually, if we're very honest, we don't have good treatments, and we know we don't. You know, I think we have to act. So the question people often want to ask is, what can I do? You can't do anything terribly useful for me, so what can I do to help myself? And I don't think we do have a good answer to that. I don't think we have good data about specific dietary. There was no evidence that a bit of alcohol is bad. I do try and kind of impress on people that as much as it is possible to do so, live your life, you know, and it's easy to say and more difficult to do, isn't it? But I think a lot of people, because of the stigma associated with alcohol still, sadly, or the association between alcohol and liver disease, a lot of people are scared to, you know, have a glass of bubbly at a christening, etc. I very much encourage that to a certain degree, because you know, you don't want to be defined by having PSC. I want people to live their lives and have PSC as the background as much as we can. But I don't think we do. I mean, healthy, balanced diet, don't smoke. I mean, the data is interesting about smoking, isn't it? But that isn't an advert to go out and smoke, clearly. No. It's quite the opposite. And I think the other thing we're probably not necessarily in PSC, actually, because I think quite often our PSC population are pretty healthy otherwise. But I think it's easy for us to forget that just because people get PSC or autoimmune hepatitis or PBC doesn't mean you can't get fatty liver disease, for example. So actually, just because you've got a rare liver disease, sadly, we're still at risk of. So it's quite easy for us to take our eye off the ball about keeping fit, keeping healthy, keeping active. Yeah. I would advocate all the, as I say, good cholesterol, good diabetes control, all those kind of those not very sexy things, but I think they're important.
And did you say that broccoli absorbs this the heavy metals? Should we avoid broccoli?
Well, so I think it's the way it's farmed. It's so farmed for food reproduction and distribution to the population, if you know what I mean. I think it's probably different from, it used to be grown specifically as a crop to suck, as I say, to suck up heavy
Right.
metals. I mean, there are foodstuffs that are high in heavy metals, but I think there are stories about other links between heavy metals and I think I want to say tomatoes, but don't take that as read. Don't take that as gospel. I don't think the evidence is good enough, and also most people don't live on broccoli.
I eat a lot of broccoli.
Oh, do you? Well,
yeah. And my kids, more importantly, actually. Yeah.
Everything in moderation. I think broccoli's other ways, isn't it? So don't broccoli on me.
Okay. Next question was, it's really interesting, thank you very much. Was radon also studies, and is there a way to test our blood for the presence of arsenic or lead?
Yeah, so again, a good question. Radon, no, I don't think that has been studied. I think now radon would be interesting in terms, so air pollution, which I suppose is partly what we're talking about there, is very difficult to study, and people have tried, but the data collection for air pollutants is pretty poor. I don't mean because people don't try, but I think it's quite difficult to do. And so I did look into this when we were looking at sources of risk factors. What's the word? I showed you that sampling map, which has thousands and thousands of sampling sites for heavy metals. But if they're in the soil, and we've also got stream sediment data. The number of air sampling sites is minuscule in comparison. So actually, if you want that detail, what I refer to as granularity, that detail, that's very difficult to do with air pollution. So know that I talk so much, it's awful. What was your second question? Oh yes.
Is there a way to test?
Yes. So I've written a study for this, but I can't get it funded at the moment. So yes, you can look for heavy metals in blood, heavy metals in bile, and heavy metals in urine. And I have written a study, but as I say, have failed to get it funded thus far, to look at a population of patients with PSC, a population of healthy, whatever that means, healthy controls, and a population of people with inflammatory bowel disease, to do a kind of, and PBC as a kind of the sistership, if you again, to do a kind of compare and contrast. We wouldn't do bile routinely because of course getting bile out of the bile ducts is invasive, but blood tests in a year, and yes, you can check for it. I've got blood samples from 850 people took part in my study in terms of giving us blood, but you can't do that analysis on the samples that are existing already. You need fresh samples, otherwise I'd do it on what we've got. So you can do it, but somebody needs to fund it.
I'll have to work on that. Next question. So this is a good question, because I was thinking about Scandinavian countries and why do they have this high prevalence of PSC? Could vitamin D deficiency, because obviously it's the cold, darker countries, be a causative factor, e.g. the trigger the immune system, resulting in IBD, PSC, hence higher number of cases in Scandinavian countries?
Well, and that, again, a good question. Chicken and egg, isn't it, I suppose, because we know that PSC and PBC, because they're the kind of bile duct diseases, you get malabsorption of vitamin D. So they're low because they're fat soluble vitamins. So if you look at vitamin D levels, and a lot of my patients that we check them routine in clinic, a lot of them are low. Also, we live in the northeast of England. We don't have a lot of sun, we have a lot of rain, and you need sunlight for vitamin D production. Now, that the study about a long-term study of low vitamin D, high vitamin D, do you or don't you get disease, has never been done, and probably never will be done. How do you do that? There is interestingly data on autoimmune hepatitis, which is, an immune system liver problem, although affecting the cells in the liver, not the bile ducts, that vitamin D deficiency may predict outcome, as in be associated with poorer outcome. That's a story. It's in evolution, and we would replace vitamin D levels in our patients with PSC or PBC or any form of liver disease, partly because it symptomatically contributes to fatigue, and whether it's good for you. Being low in something feels like it's naturally not a good idea, doesn't it? So we do replace it, but whether that changes your prognosis, I don't think. Well, we don't know the answer to that.
There has been a link with low levels of vitamin D in Scotland, hasn't there, with high levels of MS?
Yes, and the COVID story as well. people got given vitamin D and COVID by the government. Now, whether that, so the problem, and I suppose the other thing that, you know, vitamin D deficiency is so common. It's a bit like, for a while there was the story between paracetamol causing PBC. Well, almost 100% of the population will have taken paracetamol at some time. So knowing, you know, if something is so common, it's a bit like the COVID vaccines, and this is very into dangerous territory.
Yeah.
No, but what I'm saying is an anti-COVID vaccine. I'm clearly very pro a vaccine, but the labelling of vaccines causing things, it's almost impossible to know that, because at the moment, almost everybody who gets any disease will have had a COVID vaccine recently. So pulling out causation, I think, is very difficult. Anyway.
Could shellfish containing heavy metals, e.g. mussels, prawns, be a risk factor?
I suppose yes is the honest answer. We don't have data to support that, and I think, but I mean, so I can't say yes or no, but I definitely can't say no. And the data about fish being good, I think, was oily fish rather than shellfish per se. So whether, I don't know is the answer, honest answer.
So the next question is, Pers said, this is so interesting. My hepatology consultant says it's not quite what the topic, but I'll ask it anyway, that my PSC is inactive at present, but I still get some symptoms. So what does inactive actually mean?
So that is tricky to answer, because of course I don't tend to use that term myself. I'm thinking about PSC. I think autoimmune hepatitis, we tend to kind of say inactive or remission, but less so PSC. I suspect they mean, I don't know, actually that is probably not right of me to comment on that. I would guess that because I don't use active or inactive just myself in terms of PSC. I would say that in autoimmune hepatitis, but not so much in PSC. I suppose they probably mean it's not obviously progressing over time, but that's a bit of a,
it's a bit of an individual thing, isn't it? Yeah. Okay. So the next question, if a parent has PSC and a son has AIH, would it be expected that he would get PSC? Now, I know there's no genetic link per se, but would it be expected that he'd get PSC?
So yeah, so there is a genetic bit of all of the autoimmune liver diseases. And if you look at genetic risk in families, first degree relatives, so sons, daughters, sisters, parents, etc., are at higher risk than the general population of getting that autoimmune liver disease. But these are rare diseases. So even if you're at higher risk compared to the general population, your risk is still low. As I say, I look after, a lot of PBC patients and hundreds of autoimmune hepatitis patients, and I have one family who's got, well, I've got two families who've got mother-daughter pairs of PBC, and I've got one family who's got a mother-daughter pair of autoimmune hepatitis. So that's the kind of scale we're talking. So yes, people are at an increased risk in families, but they are not directly passed between generations, and we do not screen for those diseases in younger generations. And having those diseases does, I saw a young man yesterday in clinic who said, can I have a family? And I said, yes. So I would be very supportive of, ideally you want to kind of think ahead, don't you, and pre-pregnancy counselling and stuff, but those diseases in themselves are not something that would stop us being very supportive of having families, etc.
Thanks, Jess. So the next question, I understand the liver plays a role in our overall immune system, preventing diseases spreading further in our systems, and usually pays a toll when we are fighting certain diseases. SARS, MERS, COVID have all recorded incident levels of liver damage in hospital settings. Wondering if PSC could be due to the accumulation of infection and illnesses.
No, again, an interesting point. And the liver is, hugely important. I would say this as a liver doctor, wouldn't I? It's very important, but it is. And you see, so the COVID thing again, you say probably somewhere between 10 and 15% of people who get COVID get abnormal liver blood tests. And I don't mean in everybody, the whole population. So it's undoubtedly some crosstalk. We don't that's part of looking at the kind of lifestyle, life history of people, isn't it? To try and understand, and the recurrent urinary tract infection story, which is stronger in PBC actually than PSC. But again, it's a bit chicken and egg. Is it the infections that cause the problem, or is it the antibiotics, for example, that changes the bacteria in your gut, that changes the relationship between your gut and your liver? The problem with all of these things is we almost generate more questions than we do answers. That's not a reason not to do it. It's important to generate those. But yes is the answer to all of those questions, but the honest answer is we don't know.
Okay. So next question. So we talked about the gut and the gut microbe, and we know, well, we think there's a correlation there, isn't there, between that and PSC. What lifestyle changes can cause massive gut microbe changes that could possibly cause an inflammatory response, if any?
I suppose there's probably more work on this in the inflammatory bowel disease, and the fecal transplants and things are a thing, particularly in managing some very difficult gut infections. Take the old bacteria out and give them some new ones. Antibiotics undoubtedly change your bacteria in your gut. I mean, that's partly what they're designed to do in some cases. There is I don't want to go into, so there are different types of bacteria. If you look at healthy controls versus PSC patients versus other diseases, there are different, most common, if you like, that's very bad English, the most common bacteria in your gut are different. But I think the relationship between that and disease development, that step hasn't been made.
Okay. Somebody's got a question about homegrown vegetables. Don't know actually if you'll be able to answer this question, but could homegrown vegetables potentially be worse for heavy metals because the soil hasn't been assessed?
I wouldn't. I mean, the converse is probably true as well, isn't it? That homegrown vegetables are about as healthy as you get because you probably don't what you're putting on them. So and my parents spend more time than is normal at an allotment, and I'm fully supportive of that. I wouldn't be. I'm not sure that even if you knew there was something. No, I don't think so. Is the quick answer to your question, I think, actually.
Okay. There's thank you, Dr. Dyson. There's just one comment I'm just going to make from the audience, and then I think we'll sum up actually, because it's now 1:55. So a comment from member of the audience. The socioeconomic risk factors are interesting. I grew up rurally, and we would eat lots of leafy greens because you think that's really good for you. Homegrown veg, again, brown rice while growing up. And it sounds like the heavy metals in those things would make sense.
No, I mean, personally, I think the socioeconomic story is very interesting and is completely the reverse of what we see in most diseases. More disease and more affluent, overall healthier people is and Mark Hudson, who was my colleague at Newcastle, who some of you will know is now retired, always said to me there are more PSC patients over in Carlisle in the rural area. And that's partly what triggered my PhD. And he was right. There are. Turns out if you look after we look after a lot of those patients. Farming, what you do, where you live, as I say, the pesticides, is it that so I didn't show you this data and it's not published, but I do have lots of data about land use, crops, what different livestock, what you use for sheep dipping, for example, is different to what I'm not an expert in animal rearing, but sheep dips, etc. The old-fashioned sheep dips contained lots of arsenic and heavy metals, and so I think that story of rurality, whether that's employment, the land use, leafy vegetables. I mean, I realise I'm not really answering any of your questions apart from, but yes, I think undoubtedly the data from that, which we should published, is quite interesting. Again, your arsenic maps onto different forms of land use, mapping onto PSC, and I didn't show you this, but the story for PSC, PBC, and autoimmune hepatitis is completely different between the three diseases. So this isn't an autoimmune liver disease story. This is it's a different story for each of the diseases. They're not the same. And it's different again, probably for overlaps. I saw somebody mentioned overlap earlier. So that's combination disease. Anyway, I'll stop talking. Yeah, very interesting. I think it's very interesting.
I think we'd all agree with you there. It has been a fascinating discussion, and a very, you know, people have been very engaged in the discussion, and thank you for all your questions. Dr. Dyson, thank you so much for sparing us your time today.
Thank you for, sorry about my slightly tardy appearance.
No, not at all. I'm so glad that you could make it. It's been really fascinating. As I said, it's generated a lot of interesting discussion. So we're absolutely delighted with that. Thank you very much to everyone who's joined us today and watched, and some of the great questions that you asked. Really appreciate that as well. We're going to have more Ask the Experts. We are going to make them more regular. We're aiming to have 10 Ask the Expert sessions every year now. So please look out for those. Look out for the next one, and enjoy the rest of your weekend.
Thank you very much again for the invitation. Take care, guys.
Thank you.